Hello, everyone. Welcome to the Modern Management of the Older Adult Podcast, brought to you by the Institute of Clinical Excellence. I am a TA within the Older Adult Division. My name is Dr. Samantha Chamberlain, and I would like to talk to you about cardiac function, but providing that care for individuals in a standalone outpatient setting. So the reason that this is the topic is because I recently realized how underutilized cardiac rehabilitation is, and I recognize that there is a place for us at this table, and that we could really be helping people out a lot better or in a more accessible way than what cardiac rehab tends to be currently. So it's underutilized. We have a big role to step in, and I believe that we can do this. We have the knowledge, the ability, and probably the capacity to do it, and it needs to be done. So things that you need to know to be able to offer cardiac rehabilitation is you have to monitor. And if you're in an outpatient setting outside of a hospital, so it's not a hospital connected outpatient setting, you cannot call it cardiac rehabilitation. So cardiac rehabilitation under a Medicare definition has its own billing codes and all of that. It's not the 9700 series, it's or 97,000 series, it's something else. So you can't bill it like cardiac rehabilitation, but you can call it heart therapy or cardiac wellness or cardiac therapy. You can still get the point across and still offer it for the health of people's hearts, but you can't bill cardiac rehabilitation. And that sounds crazy, and it sounds like, oh, if there's certain codes for it and it's called cardiac rehab, then why would I want to offer it? And there's several reasons, and we'll get into that. But primary things you need to know is that you need to be able to monitor vitals, and you need to kind of know where their heart function is at. And you should be able to get that information from them or their doctor or their chart. Like everyone can pull it up on their phones for the most part, or has a printout from their physicians. So when you think about cardiac rehab, that definition is to have a physician on site and accessible within the building or connected building. So again, we can't offer a cardiac rehabilitation, but we can offer cardiac therapy or heart wellness programs and different stuff to people, because the barriers that do exist to get people to cardiac rehab are very high. So the point of this is to let you know that cardiac function can improve, and to kind of start thinking of it as what it is. It's a muscle. The heart's a muscle, but it scares us, and that's understandable, because if we overuse a quad, or if we make people too sore from doing too many squats or whatever it may be, they rest, they recover, they tell us about it. Like, I was so sore, I didn't want to come back. They might walk a little slow for a few days, and then they're fine. But if you fatigue a heart, it gets a little bit more risky and a little scarier, and there's usually some medical intervention that's needed beyond just resting and recovering, right? So which is likely why most PTs are not providing a cardiac program. And it's probably why most cardiac rehabilitation programs are at a hospital or within a healthcare system connected to a hospital system with a physician immediately available. So by offering cardiac therapy or a heart wellness program, we can meet these needs. And so I feel the need to talk to this and to speak to boosting your ability and willingness to take on these patients, because it's really about changing lives. When someone has an orthopedic surgery, for example, in most cases, they are offered PT in some way. And a PT intervention is needed to help regain full function, or to, efficiently do that and effectively do that, and to get mobility back, and to get confidence to walk back, or to do things that like they were doing before. But when people have heart surgeries, that's not usually the path that's followed. And if we think of the heart as a muscle, which it is, different type, but if we think of it as that, it makes more sense for us to continue the same plan of care that you would for an orthopedic surgery. So sometimes they're offered cardiac rehab, but usually it's like an option in passing in most cases that I've experienced. There is so many rural areas, I'm in one of them, but there's so many across America that if someone was offered cardiac rehab, it would require them to drive an hour, maybe 2 to get to therapy, and we're talking multiple times a week. So the burden of just traveling and transportation is a big one. They're tired. They don't want to go somewhere multiple times a week. They may not have transportation option available. The cost of transportation is getting outrageous. Again, like, there's lots of burdens and barriers that go into people not attending cardiac rehab. And then you throw in that it was kind of offered as an option and not this you need to do it. It wasn't urged. It was just kind of like mentioned in passing type thing. And it's not on people's priority list at that point. So when people have these barriers, they're not going to go. And they aren't going to treat their heart as the muscle that it is. They're going to hope that it heals with rest and recovers, and then they're feeling better. Or they take the diagnosis of heart failure to heart and think that their heart is just continuing to fail. And for many people, that is the case. But if we start framing it as a dysfunction and call it congestive heart dysfunction instead of failure, we provide a little bit more hope. And when we explain that their cardiac function can improve with proper care, then we increase that hope some more. And sometimes that's all someone needs to start getting up more and stop resting so much. So we know that the heart can become weaker, but that also means that it can become stronger. And that's what we need to focus on for people. So let's also appreciate that while I've said the heart is a muscle and we know how to treat those, there are plenty of differences that give us reason to skip a beat when considering taking on patients with heart function deficits. So you want to consider the health of the veins and arteries along with valves, and that those create an additional layer that we need to appreciate when dealing with cardiac muscle. And much like other muscles, they have neurological input. They have a big role to play from a nerve standpoint, right? So the neurological system has a role. The muscle function, the arteries, all that has a role. So thinking of AFib and other arrhythmias with neurological system, thinking of blood flow when it comes to the actual beating of the heart. So there's lots of things that make this feel risky, right? So why would you want to take this risk? And it's very simple. There's a need, and because research shows that rehab makes a difference. And as I mentioned, the barriers to cardiac rehab are vast, from transportation difficulties to lack of benefit awareness was one that I found in the research. People just don't know that it can truly help. And even a lack of automatic referral. So it's not something that's just like, okay, you have this diagnosis, you're going to therapy, or you have this surgery, you're going to therapy. There's not this automaticity to it. So that's an issue as well. And then also, we don't have a preventative culture. So we could also be playing offense with heart health as well. So you could offer, post-surgical or post-diagnosis heart health programs, but you could also offer heart health resiliency programs, so that people don't end up in this situation to where they're having these diagnoses come about. Cardiac related deaths are number one in America. That's the number one reason people die is cardiac related deaths. And so why would we not want to step up and make a difference here? If we can start preventing people dying early because their heart health is declining rapidly, then why wouldn't we? And then of course, if they do have a heart impairment on board, then we can obviously treat that as well. So I've asked several of my patients, and usually they say it was just mentioned in passing. So a lot of it is just letting people know that we can offer these services and start reducing that great disservice that as a medical system that we've done. It's not just a disservice to the life of the individual, but also the quality and the span of their life. So getting kind of back into what we can do, physicians suggest for cardiac rehab, monitored cardio, progressively increased intensity to a calculated heart rate, and increased duration at those calculated heart rates. So we have the ability to do those three things. That's not outside our scope. That is not something that we should be fearful of doing. We can do those three things pretty simply. And PTs and OTs are on the American Heart Association's list of who your care team may include in regards to heart care. So when I say this is in our scope, and although it sounds risky and that there's these cardiac rehab guidelines and all this stuff, we are still included in this list of people that can help with people's heart health. So not only are we on the American Heart Association's list of people that may be on your care providing team, but it's also in the clinical practice guidelines for PTs to prescribe aerobic, resistance, and high-intensity interval training to patients with heart disease. So primarily, we're talking about a New York Heart Association stage 2 and 3 is where we're going to be primarily focused on. Stage 4, that's at higher risk, and we're going to really try to push for them to have cardiac rehabilitation by its definition included in a hospital where a physician is readily available. But I also don't want to miss out on stage 1. That's that they don't have symptoms, but they're at high risk for developing heart disease. So that's where we can start really being preventative in our care and screening people for their risk of heart disease and maybe transitioning them into some kind of heart program that we can have within our clinics. And then kind of back to this question of risk. The reason I want us to step up and take this risk is not only because there's lots of barriers, but it's because you could really be the difference with someone's parent or grandparent and seeing those milestones in their grandkids' lives. You could definitely be the difference in someone confining themselves to their home because getting out of their house is too much effort versus actually continuing to participate in their communities and socialize and have that social group that they're able to see. And you could really be the difference in having someone around for their experienced advice, which I feel like we all need so much of right now. And without us starting to take time to treat these people, it's just going to continue to climb on those numbers of people being affected by heart disease and ultimately passing away due to not having the care that they need or knowing that their heart can improve instead of just once they get that diagnosis or once they know that their ejection fraction is low or once they know that they have coronary artery disease, they just think it's kind of a death sentence, so to speak. And it doesn't have to be. I'm not saying that you can get back to, max effort stuff from a really pushing your heart rate, but you can definitely have things be less effort. So things that you can do to start having this impact is to study up. Review heart function. We know it, we learned it, but how much do we retain? And we can all benefit from reviewing stuff from time to time. But intentionally taking the time to appreciate like the intricacies of the cardiovascular system is super powerful. The heart is obviously very vital to our health. And so being aware of like how it functions, the Purkinje fibers, the AV nodes, the cycle of the heart, like it comes into the right atrium and into the right ventricle, and then to the pulmonary system, and then back into the left atrium, the left ventricle, and then out to the body, right? But then also let's think about coronary artery disease. Like we all hear CAD, we all know about it, but have you really thought about what that means? So those coronary arteries branch from the arch of the aorta, and then they feed back into the heart, but they're not just supplying like the chambers of the heart. They are the supply. They are the blood supply for the heart muscle itself. So if someone has coronary artery disease and they have limited function or limited blood flow to the heart muscle itself, then we're going to start having cell death. The heart gets weaker. It's not pumping as well. We're not getting all that blood out into the body at that point. We're not getting it as well oxygenated. Lots of things go into that. And when you better appreciate that, it becomes a lot easier to know why we're monitoring, what we're monitoring for, and you can also better explain it to a patient. You can have better conversations with the cardiology office and knowing how to speak to those providers and know what you're talking about and feeling confident in it just by kind of reviewing the anatomy helps a ton. So think about those things first. So review that. It doesn't take long to review that heart system. And then go talk to local cardiologists. Sometimes a lot of metropolitan areas have cardiologists that come to rural clinics a couple times a week. So if you're one of those people that are in the rural clinics, go to the cardiology office, let them know that you saw a need and that you are providing these services. If you are in the city, same thing. They're overloaded. They have too many patients. They can't see all the people that need to be seen and they don't know where to send them. So go and let them know that you can provide these services. And of course, when you let them know that you notice a gap in care, you can frame it as we just know that the population is growing and the need for this is growing. So it's not like, oh, you failed to sit this referral in. You're not putting the blame on them. You're just recognizing that there's a need for more providers in this space. And then market to the consumers. Most states have some sort of direct access. So even if you do have direct access, you're still going to want a physician signing off on your plan of care with these individuals because you want to be able to have that communication with the physician, whether it's their primary care physician or their cardiologist. You can talk to the patient and ask like kind of which they have a better alliance with or a relationship with so that you can know who's going to be better to communicate about the patient and get them to sign off on your plan of care. That way you can continue your care on and it's kind of being monitored by a physician, but you can also have that communication pretty easy if you start to notice some things that are amiss or need to be addressed from a medication standpoint, or maybe their heart is getting healthier and their blood pressure is coming down and now they're getting dizzy because they're still on medications for that. So there's lots of reasons to have that communication already going before something does come up. But market to the consumer. So by letting them know the benefits of cardiac rehab, such as it reduces return to the hospital after a cardiac event. Those rehospitalization rates go way down when they're in some kind of supervised therapy or supervised exercise program. It improves their activity tolerance. So walking from their house to their car starts to become less of a challenge, right? We're not working at an 8 out of 10 RPE anymore. We're back down to like a 4 out of 10 to get there. And it's a long haul. Like this is going to be an 8 to 12 week program. You're not giving them 6 weeks and then saying, see you later. You're doubling that. You really need to be at that like 12-week mark to truly have those benefits. And then you're trying to push them to a exercise program like Silver Sneakers or a local gym or senior center that has regular exercise. But you're going to want them to know that it needs to be at a high intensity. Yes, I just said high intensity for cardiac therapy. We need these people pushed at a higher level than what we're usually comfortable with. But to do that, we have to provide a lot of education to the individual. They have to be able to self-monitor their symptoms, because if they don't, then that's when they start getting in trouble, right? Interval training is the best way to do this, because you do 10 seconds of high intensity and 50 seconds of rest to get their heart rate back down so they're not like pushing those thresholds. Then you can bump it up to 20 and 40. So you can see this change pretty progressively and pretty quickly, which is really helpful for the patient to feel, again, more hopeful that they can make improvements in their health. So other ways to market to them is letting them know that it improves their heart rate, it improves their blood pressure, helps them to have improved health and resiliency overall. You're helping them to live a healthier life with a better quality, instead of feeling like they can't do the things they want to do because they know the effort that it's going to take. You want to provide a lot of resources to these individuals. So the American Heart Association has a self-check plan list, and it's really nice because it has like a squared off spot that's in green, a squared off spot that's in yellow, and a squared off spot that's in red. So if it's in green, they're good to go. They're cruising right along. If they're in yellow, then that is reason to call a physician or get a cardiology appointment. And then if they're in red, of course, they're probably needing to go to the emergency room or seek some kind of care because of those checklists. So things that are on this checklist are things like dry weight. So you want to make sure that your patients are getting specifically for congestive heart failure, but really any kind of new or onset heart disease where heart failure could occur. You want to get them a dry weight, which just means after they've gone to the bathroom in the morning, before they've ate or drank anything, get on the scale. Well, what if they can't get on the scale? Let's think about how you have to step up onto and then back off of the scale. Maybe you teach them to step laterally onto it. Sometimes that's a little bit easier, so they can step on it laterally while holding onto the counter. But you want to make sure that they can effectively do that, as well as look down, because on a scale, you have this narrow base of support, and now you're trying to look down, and not everyone can do that, and we assume that they can. So when people are asked, are you taking your weight? And they say no, it might not be because they're forgetting. It might be because they don't feel able, but they don't want to tell you that. So kind of screen for, are they able to take their own weight? So that's an education piece. And then let them know why they're taking their weight. If they have a change of 2 to 3 pounds in a 24-hour period, or 5 pounds in a 3-day period, then that's kind of that yellow. They need to let someone know they might need to get checked or their medication adjusted or something because they're holding too much fluid. So checking their weight's really important for them to know how to do, and you to make sure that they can do it. The self-check plan is helpful because it has that on there. And then also monitoring their heart rate, monitoring their blood pressure. They should know how to do that. You want to give them thresholds, though. So just because they're checking it doesn't mean they know what it means or know when they need to call or talk to somebody. I've had a lot of patients where I've checked their blood pressure and it's been like 190 over 100 or 190 over 110. And they're like, oh, yeah, that's good. That's normal for them. No, this is not good. But it's because it was so high when they went to the doctor. Like this specific person I have in mind had a stroke. It wasn't necessarily heart rehab they were needed, but they thought that was completely fine because it wasn't 200 over 120 or something. So they're like, oh, yeah, that's good for him. No, it's not. That's a problem. We need to make some adjustments and figure out what's going on there. So giving them those guidelines, like if it's getting over 100 and it's staying there consistently, or 180 and it's staying over there consistently, we need to go to the doctor. If it's if the diastolic number is 110 and it's staying there, we need to go to the doctor. So if they're consistently getting these numbers, they need to seek care, right? And sometimes they don't realize that. They're just kind of told it arbitrarily. Like, if your blood pressure gets high, well, what does that mean? Okay. So give them some guidelines. You also want to educate them on the Borg dyspnea scale. And that's like how much effort it is just to breathe at any given time. So you can have them do it at rest, during your exercises. You can have them start kind of keeping a journal or that self checklist of when they get up to go to the bathroom, or when they get up to do laundry, or when they're doing, like, depending on their functional level, what are they hanging out with? Like, is it hard to breathe when you do these things? How hard is it? So then they can track their progress or track any declines that they may have. And then just a regular RPE scale. So I like the modified version, 1 to 10, 10 being max effort, 1 being just at rest. You may catch people that at rest, when they have heart dysfunction on board, they are at a 4 out of 10 just sitting there. Like, it's work to just sit up. So this is really helpful. If you use the traditional RPE scale, that's 6 to 20, just know that you can think of that or correlate that. Never understood why it was 6 to 20 until a few weeks ago. 6 is correlated with 60. So at rest, you can think of their heart rate should be around 60 beats per minute. Whereas if they were at their max effort, really having a hard time, you're going to be at that like 18 to 20, so 180 to 200 beats per minute heart rate. Correlating that with patients may help. But again, the 1 to 10 scale people do really well with. I personally like the ones that have faces on it, but some people might relate better to like the talk test and stuff like that. For outcome measures, we are going to want you doing things like 2-minute step test, 30-second for endurance, and then 30-second sit to stand, or a 5-time sit to stand for strength. And then also use 1 rep max calculations. And each of these things you want to get RPEs with as well, because maybe their time didn't change on the 30, or their reps didn't change on the 30-second sit to stand, but they went from it being an 8 out of 10 effort to a 5 out of 10 effort over a 4-week span. So that's a big win, right? If they're starting to feel like things are less effort, then that's huge. But have them practice that RPE scale with some daily movement so that they start to understand it and can have that self-symptom check. And then just know, like, to wrap things up, there is a need, and I have no doubt that you would start getting patients in this area if you started marketing it or letting people know that you can help them in this area. We are very capable to step up in this role and inform healthcare providers in the communities that we can help them. So you want to make sure that you're getting good blood pressure, taking vitals before, during, and after therapy, that you're taking oxygen saturation, that you're checking their heart rate, and that it's not getting too high. You need to know the contraindications and you need to monitor them. So kind of know where those thresholds are for blood pressure, know when you need to contact the physician, and know when you need to contact emergency services, because there is a difference there. Like, sometimes physicians are okay with having things a little high, kind of towards the subacute phase of any heart event. But you need to be aware of those thresholds. And then keep in mind that exercise capacity is going to be lower. It decreases by like 30 to 40%. So that's where I'm saying, like, resting, they're not probably 1 out of 10 RPE. They're probably sitting at a 2, 3, maybe even a 4, depending on the severity of their heart function. So, or their lack of heart function. So keep that in mind. Exercise intensity. I said we want to do high intensity interval training, but you want to think about keeping their heart rate about 30 to 50% above resting heart rate. So if someone has a resting heart rate of 70, they probably wouldn't need the heart health program, but maybe they would. We don't know what's going on. But for example, 70, you're going to times it by 0.3, 0.4, 0.5. Let's say you did it by 0.4, so you wanted them working out at 40%. That's 28. So 70 plus 28 is going to be 98. So we don't really want to push them past 98 beats per minute. Doesn't sound real high. You could probably get them pretty quick. So try to maintain 98 for whatever your interval is for that day. Let it come back down and then go again. And then if they have any onset of signs and symptoms, and then you want to also monitor gait speed. So that's another outcome measure that you can get, and start trying to improve their gait speed to get it up to where it's 0.8 or down to 0.8 or 1.2 meters per second is kind of the threshold of it's a good vital sign. It's a good thing to check where their gait speed is at, because it gives a general ability of function. So truly just know that you can do this. You have the capacity to do it. It is in the clinical practice guidelines for us to provide these services and to be on the team for providing care to people's heart muscles as well as their musculoskeletal muscles. So just know that you are very capable. A quick review of anatomy can be super helpful, and you can really make an impact on people's lives and their quality of life and their health span in general. So give them the good news, give them the hope, let them know that one cardiac event or chronic heart disease or anything that they have going on doesn't necessarily mean that they're on this downhill spiral, but can rather focus on their health and really make a difference with exercise, like especially supervised exercise, but giving them the tools they need to know to monitor their symptoms and what to look for can also be very empowering because they feel like they have more control over their health. And then if you need one more little nugget to help you feel confident about this, during COVID, they had cardiac rehabilitation programs and hybrid cardiac rehabilitation programs, whether it was a phone call or patients doing videos at their house, had similar outcomes. So it was just it was compliance more than anything and self-monitoring. So if we can teach patients to self-monitor and do this safely without adverse events, I have no doubt that you guys can also step up and provide this care with safety and providing this care to individuals. So just make sure that you're checking those medications as you go through the program and asking about any changes in their medications because we have a role in that as well. So if you have any questions, if you want to hear more about this, let me know. I've kind of been nerding out on the heart lately, so I love talking about it right now. Upcoming courses for MMOA, we have 2 live courses on August 3rd. They are in Newark, California, as well as Salt Lake City, Utah. And then August 17th, we'll be in Anchorage, Alaska. So if you are in that far northwest area, that would be the time to come. So we have the West covered the first half of August. So feel free to come see us live. We'd love to have you there. And then Level 1, the online 8-week course, Level 1 starts August 14th. And then our next Level 2 course starts October 17th. So if you want to come hang out with us, learn more about cardiac rehab or anything else older adult related, come see us.